Hey, thanks so much for joining us today on GM Insights. If you've been watching the calendar, we're doing this a week early just to make sure that we're not interfering with people's holiday plans. And so today we've got a special event for you. It's Dr. Jim Law, MD, PhD, who is the Allison Roy Richards Endowed Chair for Alzheimer's Disease Research. He is a basic scientist and a clinical researcher. He directs Georgia Memory Net, the statewide program for early recognition, evaluation, and treatment of patients with Alzheimer's disease and related dementias. He was recognized as the outstanding Georgia citizen in 2019, based upon then Commissioner Barbara Crittenden's proclamation, well-deserved. Dr. Law has a really big, important topic that's been in the news a lot, and he's got a little bit of time to do it. And so we'll go ahead and show the disclosures. Not surprising that Dr. Law has engagement in this space, as he should as a clinician researcher and a basic science researcher. And so I'll ask just for Dr. Law to give us a brief elaboration on some of the things that he's been funded to do and how that relates to the important things that he's talking about today. So Dr. Law, I'll go ahead and turn it over to you, and I'll let you take it from there. And Lori, if you could show that first disclosure slide, and we'll have Dr. Law just offer a bit of context. Thanks. Thanks. It's all yours, Dr. Law.
Yeah, so I misunderstood, and I put I'm going to go ahead and take over the share, if that's okay, Lori. I went ahead and added a disclosure slide after you mentioned that to me, Ted. But my only relevant disclosure, which really isn't relevant for purposes of today's discussion, is I do serve as a consultant for Roche Diagnostics. And I was asked to talk about current developments in therapeutics for Alzheimer's, which I think many of you have heard about. But I want to go back to the National Alzheimer's Plan Act, which was signed into law by President Obama back in 2011. And this was, it seems like forever ago now, but the part of this that has had the most press is that one of the primary goals, as laid out in NAPA, was the prevention and effective treatment of Alzheimer's disease and related dementias by 2025. And it seemed like a pretty reach goal, and has seemed ever farther and farther away with every failure that we've unfortunately had to suffer over the years. But we have had some recent success, thankfully, which is what we're going to talk about. And just the obligatory sort of introductory slides on Alzheimer's. So this is everybody's favorite picture of Frau Auguste Dieter, who was Alois Alzheimer's index patient, who developed symptoms at a very early age and was felt to have a very rare, unusual disorder that Alzheimer's studied during life and after death, and recognized that there were certain changes in her brain that have come to be recognized as universal pathologies in Alzheimer's disease. So keep in mind, these amyloid plaques and tau tangles have been known since the early 1900s. And because of certain advances in molecular genetics in the 1990s, so 90 years after Alzheimer studied Frau Dieter, the amyloid cascade hypothesis came to dominate the field starting in the mid to late 1990s. And that hypothesis really says that that the initial production and accumulation of these abnormal deposits of amyloid protein in the brain is responsible for triggering a whole cascade of events that ultimately leads to extensive neurodegeneration, clinical symptoms of cognitive decline, functional decline, and progressive dementia due to Alzheimer's disease. And an important corollary to that, and I'm reminded again that I don't think I changed this slide since I created it back in the late 90s or early 2000s. Because an important corollary to that is that prevention of the amyloid accumulation might do something in terms of slowing or preventing the development of symptoms of Alzheimer's disease. And that hypothesis has been tested many, many times over the last couple of decades. And one of the important learnings during that time is that we have come to firmly understand Alzheimer's disease as a chronic disease, no different from heart disease or cancer or progressive kidney disease or anything else. Because those conditions, somebody doesn't wind up in end-stage renal failure overnight, just like you don't have a massive coronary massive infarct based on blockages of coronary arteries that happen overnight. These things accumulate and progress over a period of many years and decades. And that's no different for Alzheimer's disease. We have come to understand that in this graphic, if this green line over here is, if this green line over here is clinical decline with increasing height of this line representing greater cognitive and functional decline, by the time we see those symptoms begin to emerge, we now understand that the pathology, including the amyloid pathology, has been evolving for up to 20 years before initial symptoms start. And so there's a whole series of events, that whole cascade that is not all depicted here, just the salient pathologies of amyloid plaques and neurofibrillary tangles. Those changes are accumulating for decades before somebody develops Alzheimer's disease. And this has become abundantly clear. Early trials, in fact, the very first clinical trial targeting amyloid occurred in 1999, before the millennium. And in that trial, individuals were enrolled who were in advanced stages of dementia, really quite severe Alzheimer's disease, and it was unsuccessful. And over the years, the anti-amyloid treatments have been applied at different stages in the course of this progression. And then more recently, the focus has come into the very earliest stages of mild cognitive impairment and very mild dementia. And most of these studies now depend on the use of amyloid PET tracers. So this is a series of amyloid PET scans. The top row, you see axial images. The middle row shows mid-sagittal or roughly mid-sagittal, and then the coronals in the bottom panel. And each column represents an individual with different amounts of amyloid pathology. And so in control individuals who basically have no amyloid pathology, this is the general appearance. There's very little accumulation of cortical signal for the amyloid tracers. But then with increasing deposition and density of amyloid pathology, you see an abundant accumulation of this signal, and this is reflected in a couple of different ways. SUVR is just a relative uptake of signal relative to a negative area, but there are different ways that you can measure the accumulation. But you can detect this in patients before any treatments, and then you can also evaluate what happens after treatment. So this is a panel that came from data that came out of a gantenerumab study. So gantenerumab is another anti-amyloid antibody. And here what we're looking at are amyloid PET scans from a series of patients over time. So each patient is represented in axial sections in the columns. And then the horizontals represent the baseline PET scan. And then the amyloid PET scans in those individuals seen after 52 and 104 weeks after treatment with gantenerumab. And so if we just focus on patient 3 and look at their amyloid PET scans in greater detail, you will see that after 52 and 104 weeks of anti-amyloid treatment with gantenerumab, the intensity of these signals is basically about the same as those individuals that were amyloid PET negative on that first scan I showed you. So gantenerumab, donanemab, lecanemab, aducanumab, All of these anti-amyloid antibodies are able to do this. They can clear the amyloid effectively out of the brain. Some of them do this more effectively and more rapidly than others do. They have slight differences in the antibody epitopes, but they do tend to favor binding of the protofibrillar form of amyloid, and they all have the effect of removing the amyloid accumulation out of the brain. But remember, this amyloid plaque buildup, I said, occurs over a period of 2 decades. So one of the questions has been, well, if we're looking at a pathology that's been evolving for 20 years, does it matter if we remove this amyloid 20 years after the fact? We certainly have proven that eliminating or targeting amyloid out here in more moderate stages of the disease has no clinical impact whatsoever. We've proven that abundantly. But the question has yet been unanswered. If we can approach this treatment early enough, will that do anything? So I'm going to take us back a year to actually a little over a year and a half now, to the controversy with aducanumab. So I think many of you will remember this because it created quite a firestorm. So I want to review what the story with aducanumab, because it is both informative and relevant to the current story with lecanemab. So what happened with aducanumab is, this is just a graphical representation of the SUVR values, the relative intensity of the signal of the amyloid PET scans in individuals who were treated with placebo over a period of 18 months versus individuals who were treated with the highest dose of aducanumab in the blue. And what you saw in 2 very large phase 3 trials, Emerge and Engage, is that by a year and a half of treatment, most individuals who were treated with the highest dose of drug essentially had undetectable amyloid pathology by amyloid PET. So that was expected and certainly encouraging. And in the Emerge trial, the primary endpoint changed from something called CDR sum of boxes from baseline. The difference between those individuals treated with placebo and those individuals treated with highest dose aducanumab was significant, with about a 22% slowing in the worsening on the CDR sum of boxes. However, the second trial, Engage, which was just as large and just as well designed, both enrolled about 1,600 individuals with almost an identical trial design, showed no significant difference. So one study clearly showed benefit, and the other study clearly did not show benefit. Biogen chose to proceed with FDA submission anyway, and there was a lot of controversy. The advisory panel almost unanimously recommended denial of the Biogen application, but FDA decided to do something a little bit different, and they applied a process, something called accelerated drug approval process, which was developed back in the 90s and during the AIDS epidemic. And many of you will remember back in the 80s and 90s, getting HIV infection was essentially a death sentence. There was no cure. You were going to get immunodeficiency and you were going to die. There were some promising developments that were coming out of the research arena that suggested that certain agents could either reduce retroviral load or could increase measures such as CD4 counts, which were felt to be a reasonable alternative or surrogate that would predict clinical response. And in fact, it was true. Those medications did prove to be clinically beneficial based on the surrogate endpoint. So this accelerated drug approval process has been in place and has been used for a number of other medications, including cancer medications. So what FDA said was that we are going to accept amyloid clearance as a surrogate for clinical response, as a predictor of clinical response with aducanumab. And so using this as a rationale, they gave accelerated approval of aducanumab. So that's where the controversy kicked in, because normally for FDA approval, for full drug approval, you expect to have clear evidence of clinical benefit before the drug is approved. And so then CMS had to make a decision on national coverage decision, whether they were going to pay for this extraordinarily expensive drug. And just the anticipation of that led to the single highest bump in Medicare premiums in Medicare's history. And what CMS decided was, yes, we will pay for this drug, but because the evidence for clinical benefit is so limited, we will only pay for this drug if it is given in the context of a randomized clinical trial to prove its benefit. So essentially kicked aducanumab back to the stage of clinical trials, although it is available, and we know people who have been able and willing to sustain the cost of the drug to receive aducanumab clinically. But CMS also did something else that was very important for current discussion. And they added on to the national coverage decision contingency for other amyloid therapeutics. And what they said was that if there is evidence of both amyloid clearance, surrogate marker removal, and evidence of clinical efficacy, CMS would cover the cost of the medication in the context of comparative studies. So basically a registry where there was regular evaluations so that we could accumulate real world data on the efficacy of this medication. And for GMN, basically what that means is what we currently do. We will have to modify things so that we have longitudinal cognitive and functional data collection, but we would be in a position to meet this requirement. And this was, this was relevant for gantenerumab, which recently revealed top-line results that did not meet primary endpoints. But we're going to talk about BAN2407, which also goes by the name of lecanemab, which did meet primary endpoints. And Lilly's drug, donanemab, is still in phase 3 trials with results expected, I think, in early 2024. So what happened with lecanemab? Well, just like with aducanumab, lecanemab eliminates amyloid pathology. So this is, again, amyloid PET scans. And in this case, they use something called centiloids. And by 12 months of treatment with lecanemab, the signal for amyloid PET was undetectable for most individuals who were being treated, and certainly by 18 months. But what was really encouraging is that treatment with lecanemab also resulted in a 27% slowing of the change in baseline, change from baseline cognitive and functional assessment. And this was the primary outcome measure, the CDR sum of boxes, comparing placebo, which showed a steeper decline, to lecanemab, which showed a 27% slowing. One of the really nice things about this study is that it was extremely consistent in all of its outcomes, both primary and secondary and biomarker. So there were cognitive outcomes and functional outcomes based on ADAS-Cog and the ADCS MCI-ADL scores, which were significant in favor of lecanemab. In terms of biomarkers, so the amyloid biomarker, A-beta 42 in the spinal fluid, when amyloid deposits in the brain, the levels of the CSF A-beta tends to be lower. So higher levels of A-beta 42 is actually desirable. And compared to placebo-treated individuals, the spinal fluid of lecanemab-treated individuals showed a significant increase in the levels of A-beta 42. This is based on picograms per mil. So a pretty significant increase. And then the tau proteins, the total level and a phosphorylated form of tau, are elevated in the spinal fluid in Alzheimer's disease. And compared to placebo-treated individuals, both tau and phospho-tau showed a significant decline in individuals who are treated with lecanemab. And one of the things that we're anticipating in the next couple, 3, 4 years is the application of plasma biomarkers, blood-based biomarkers, and they also looked at this as a secondary outcome in this study. And just like in the spinal fluid, the levels of A-beta 42 in the plasma in individuals treated with lecanemab went up compared to individuals who were treated with placebo. Likewise, the levels of the phospho-tau protein declined in lecanemab-treated individuals, and another neurodegeneration marker, GFAP, also showed decline in lecanemab. So across all of these clinical measures, cognitive measures, functional measures, CSF and plasma biomarker measures, as well as the amyloid PET measures, the results were extremely consistent. One other way to look at this, because one of the questions that comes up is, well, okay, so those are all statistically significant. There were like 1,200 people in this study. And what is the clinical meaningfulness of this? And one of the ways to consider this, and this is a plot of of progression based on the global CDR, and which is just a measure of global assessment. And you see this stepwise pattern because these were done at 3-month intervals during the trial. And so what you see in the placebo and drug-treated individuals is that over time, their global CDR score is going up, indicating worsening sort of cognitive and functional status. But there is a separation, as with other measures, on the lecanemab-treated individuals. So one other way to look at this is if we smooth that out into a linear curve, into lines, straight lines, and you look at the trajectory of individuals worsening functionally that were placebo-treated versus those who are worsening functionally with lecanemab, and then look at the time and say, okay, well, if we look at different time points for individuals that would reach this level of disability, how much time am I buying with lecanemab before an individual who's treated with drug reaches that same level of disability? And what's interesting is when you plot this out, over time, that separation appears to be increasing. And we don't have data beyond 18 months, and this isn't a true comparison. But as you project that out, what that's telling you is that over time, there is a greater amount of time that an individual will spend at earlier stages of disease than at later stages of disease. So to look at this a different way, if, say, at this stage of disease, an individual has lost the ability to drive, and a person who is treated with lecanemab doesn't reach that stage of disease for 6 months. So think about what the changes, the slowing of decline means in terms of retaining functional abilities. So this is a really important.
Hey, Jim.
Advantage. Yeah,
Jim, if you could back on the last slide just for a second, could you just give us a reminder of the CDR and sum of boxes and kind of what the scale is? Thanks so much.
Yeah. So this is so they did not provide the CDR sum of boxes. So this is a rate of progression measure, not CDR sum of boxes score. CDR sum of boxes goes from 0 to 3. Within 0.5 increments. So 0 is completely normal, 0.5 is typically MCI. And so I don't have that direct translation. I stole this idea from a webinar that one of the folks at ASI presented, and I thought it was an effective way of looking at it, but I didn't have access to the actual CDR, global CDR data to present it that way.
No worries, and thanks for pointing out that this is a failure analysis, meaning how many people reach an undesirable endpoint.
That's right. So now lecanemab has sort of met criteria for a standard FDA approval. They are scheduled for a preliminary meeting with FDA in January. And then the question will be how long FDA takes to make a final decision. And typically CMS might take as much as 9 months before achieving a national coverage determination. So we don't know how long this process is going to take, but most people anticipate that the drug will become clinically available sometime middle or late 2023. And we will have to have another discussion because I've only talked about the sort of nice stuff, but there are risks associated with this drug and requirements for monitoring for safety that Dr. Hales and I are actually going back through, reviewing the the guidelines for initiating treatment as well as monitoring and exclusionary factors. But this is an important advance. This is the first of its kind of a disease-modifying therapy. And the reason those are important is because Alzheimer's and related dementias are terrifying, justifiably, because they get worse over time. And if you live long enough, you can anticipate reaching a point where you have a profound loss of abilities and a terrible quality of life and tremendous burden to families. But if you can slow the course of disease, that means that we may be able to spare many patients and families those worst stages of disease. And then importantly, if we advance this to the point of prevention and delaying, if we can delay the development of disease and ultimately prevent the development of disease, then we're really defeating the disease more globally. And so as last two slides, I just want to mention the AHEAD study because the lecanemab results wind up being very encouraging for this study. So the AHEAD study is a secondary prevention trial that is looking to determine if removing amyloid can be helpful in preventing cognitive decline in healthy individuals. So the screen in this study is for individuals over age 65 or people who are younger but have an ApoE epsilon 4 risk allele or a first degree relative who had AD before age 75. And based on that screening, individuals will then get an amyloid PET scan. They have to have a positive amyloid PET scan. They have to have evidence of Alzheimer's pathology, but be cognitively normal. And then those individuals are going to be randomized to placebo or lecanemab, the same drug that we've just been talking about that's beneficial in MCI, as a secondary prevention therapy every 2 weeks for 4 years. And so it's a really encouraging time, both in terms of the imminent availability of a new therapeutic, the first new therapeutic in over 20 years for Alzheimer's disease, but also the advent of disease-modifying therapies and hopefully the not too distant proof of disease preventing or delaying therapeutics. So I've left all of 55 seconds for questions.
But we're gonna make it work. Thanks, Dr. Law. Really appreciate you. This was a great session, and I know that you've been working a long time in your career to wait for this type of being on the cusp of having easy to use and readily available disease modifying therapies. We still got some way to go, but these are all exciting developments. Sonia Green, our APP chief in primary care, asked a really important question. You were talking about amyloid PET scans in the context of research, but she wants to know about the clinical utility of these, how they're available, whether or not they're paid for, and what you might use them for clinically. Thanks.
Yeah, that's a really great question. We don't use it clinically currently because nobody's paying for it. I didn't mention the spinal fluid measures. We tend to do AD biomarker testing in the spinal fluid because that's much more accessible and it's covered by insurance. What CMS indicated in their previous coverage decision is that they would also consider covering amyloid PET scans for individuals who are going to be treated with anti-amyloid therapeutics. And it opens a kind of a can of worms because there are things that we will have to consider. So if you eliminate all amyloid by 12 to 18 months of treatment, do you still need to give this drug every 2 weeks? And if you don't have to give it every 2 weeks, when should you give it for maintenance? Do you have to do an amyloid PET scan at the beginning and at 12 months and at 18 months? Is CMS going to pay for that? How is that going to work? Those are really important questions. We anticipate that Medicare is going to approve coverage for at least one amyloid PET scan, but how it's covered and accessible clinically beyond that is going to be an important question to answer.
Thanks for that answer. We have a question from Birju Patel, who's a geriatrician and also one of the leads at the VA MCI clinic and cognitive clinic. And so Birju's question was about the function. Like, you know, we have some functional measures in the CDR sum of boxes, but what do you think are the appropriate functional measures that we should be looking at? How is amyloid reduction going to be correlating with these functional outcomes? And then we have one question from Carolyn that we'll get to next. Thanks.
Okay, so the functional measure that was incorporated into the Clarity trials was the ADCS MCI ADL questionnaire, and I've actually been looking at that because in the network of GMN memory assessment clinics, we routinely are collecting the functional activities questionnaire, which is the same functional scale that we use in the network of Alzheimer's disease research centers. Both of those, the MCI ADL scale and the FAQ, are more geared toward instrumental activities of daily living, which is, I think, what would be more appropriate in this context for MCI and mild AD patients. The other sort of basic ADL questionnaires have too low a ceiling, and I don't think would be appropriate as longitudinal measures.
Jim, I don't know if you could see the chat to read Carolyn's question. It's wordy, but it's good. Every word counted. Clinical trials for these therapies seem to be highly consistent in their data elements, amyloid, centilloid, CDR-SB, ADS-COG, but inconsistent in who they actually enrolled.
So yeah, so every study is a little bit different, and the centilloid scale, in terms of the amyloid, so there were differences in the average intensity of the amyloid signal. The populations that are enrolled, they generally are. I think what's fair to say is that all of these trials generally have amyloid positive individuals. And so one big advance over the years has been not a clinical enrollment based on MCI criteria, but an etiologic enrollment based on cause of MCI and mild dementia. The other important sort of inconsistency, and I did not give ASI credit for this, aducanumab was disastrous in terms of the lack of diversity of their enrollment, their population. Clarity was done worldwide, and they actually had sites in Asia, South America, Europe, as well as US and Australia. And they still only had under 5% African-American representation in the trial, but they exceeded their Hispanic enrollment. So their target for Hispanic enrollment was 20%, and they exceeded that. So I give them credit for that, but the participants in these trials are really limited, and and somebody, and Carolyn put in the chat that Gantt had 1%. The aducanumab trial, we looked at how many African Americans got high dose drug, 10 milligram per kilogram dose, and it was 6, a total of 6 people. And so there are a lot of differences, but the nice thing about the Clarity trial, again, was the robustness and the consistency of the results, and there also appears to be greater efficacy in terms of amyloid clearance and Clarity versus the gantenerumab as well. So it appears to be a little bit less effective at removing amyloid.
Dr. Law, thank you for giving us a special date for GM Insights. We really appreciate you not only for breaking attendance records today, but also for your leadership in Georgia MemoryNet. And as you pointed out during your talk, Georgia MemoryNet is really designed and built to help with what comes next. And so we're really excited about this. I wanted to give 2 other shout outs, one to Dr. Gabriella Cohen, who's been our course director for GM Insights. A round of applause for her. We really appreciate your leadership in helping us put together informative programming. Not only can you fill out your evaluation here by scanning the QR code, but also there are ways in which you can link and go back to other sessions that we've had before. And also a big shout out to Lori Beth Bryant, who's been our administrative supporter for this program and has been doing literally 2 jobs. And so we really want to give a shout out for her. Thanks for joining us today.
Thank you.
This is our 11th session, our session of 2022, and we've got approval to do a whole year of sessions next time. So we're looking forward to it. Hey, thanks so much. Really appreciate you. Thanks for joining.
Thank you so much, James.
Happy holidays, everyone.
Happy holidays. Thank you.